Now, in order to get a better understanding of this, I want to bring in someone that is well trained in emergency medicine. Dr. James Neuenschwander is joining us now. Dr. Neuenschwander, the first question I have, and first of all, thank you for joining me, is I think for most of us, what he describes at the end of this video is that he's moving into a different protocol to use oxygen first. My understanding was a ventilator is oxygen. So for those out there that are maybe missing the significance or the detail or the difference between them, what is the difference between giving oxygen and using a ventilator? Can you take me through that process?
Sure, Del. So you can deliver oxygen in a number of different ways. A ventilator is just one way to deliver oxygen. And the difference between a ventilator and just having a nasal cannula or a face mask is that this is still using your own respiration. You're breathing the air in, you're creating a negative pressure, you're sucking the air into your lung. When you use a ventilator, you're pushing air into the lung, and that creates a completely different dynamic. The other thing is, once you paralyze a person, now you're completely depending on that ventilator to do all the breathing for them, and it's very much dependent on how you set up that ventilator, and that's what he was talking about in terms of maybe we're setting this up the wrong way.
Very interesting. You know, and I want to point this out. He is no longer all alone. I mean, this was just a few days ago. It was the first that I've heard of it, but now we are seeing a report. This was just in the Chicago Tribune yesterday. Let me read this. Some doctors are moving away from ventilators to treat coronavirus patients. The reason? Unusually high death rates. It goes on to say, as health officials around the world push to get more ventilators to treat coronavirus patients, some doctors are moving away from using the breathing machines when they can. The reason? Some hospitals reported unusually high death rates for coronavirus patients on ventilators, and some doctors worry that the machines could be harming certain patients. Generally speaking, 40 to 50% of patients with severe respiratory distress die while on ventilators, experts say, but 80% or more of coronavirus patients placed on the machines in New York City have died, state and city officials say. Now, why would they be dying? I mean, so first of all, what damage can be done by a ventilator that's not done by oxygen? What are they talking about? What are the risks that, you know, all of them? What drugs are being used? What is the process of putting someone on a ventilator?
Well, typically, you're going to give somebody some type of sedation. You don't really want them awake. You're going to paralyze them, and that's one of the biggest reasons to give sedation. But you're going to paralyze them, and then you're going to put the tube down their throat, and you're going to put them on the ventilator. Now, once you're on a ventilator, you usually have to have pretty heavy sedation. Otherwise, you're going to be fighting this thing. So once that tube is down and you're putting that pressure in, the idea is you're trying to minimize the pressure you're using to get the job done. Because the higher the pressure is, the more likely you are to damage those lungs. I mean, the lungs are kind of delicate tissue, and you don't want to get too much pressure. Now, what they're talking about and what he is talking about is different treatment protocols. They're treating this early COVID when they're being put on ventilators as though it is like ARDS, which is sort of an end stage of a typical pneumonia kind of infection. And what they're saying in these studies is it doesn't look like that's what we're seeing on CAT scans or what you're seeing on physical exam. So the pressure that they're using can damage the lungs, and that may actually make the situation worse rather than better.
Is there, you know, so when we reached out to you to start looking into this, you know, of course, this is brand new. This doctor could be wrong. I want to make that, this is brand new, a breaking story. But for those of you that are following the Highwire for the first time, we investigate with you. We are not going to come to the answers, then just bring you the answers. I am talking to Dr. Neuenschwander really for the first time. We like to have the investigation out in front of you. We have an MD in New York that is demanding that the international body of scientists come together and try and help with this issue. Now, when you heard the things that he was saying, that I don't believe this is a pneumonia. I don't see fluid in the lungs, that there appears to be much more flexibility to these lungs, that they don't have difficulty moving their lungs, which is why you would use a ventilator. They seem to be starved of oxygen. What were your thoughts on that, and where did you look to try and see, is this a different type of illness?
Yeah, well, it turns out that one of the doctors that was involved in northern Italy, in the outbreak in northern Italy, Dr. Gattinoni, actually published an editorial piece in one of the journals, and he showed differences in the CAT scans between these patients. So when you typically look at a CAT scan from a patient that has classic ARDS, which is what all these protocols are for, their lungs have fluid in them. They're whited out. There's a lot of heaviness to the lungs. But you look at the CAT scan of patients that are in the earlier stages of COVID, where they're short of breath and they don't have very good oxygen saturations, and their lungs don't look that bad. They're dark on the CAT scan. There's plenty of oxygen. The entire lung looks like it has air in it, and it's not all collapsed and full of fluid. So he actually published that probably a week ago. It's just, it takes time for this stuff to come to light, and there are just paper after paper after paper every day trying to figure this out. So you have to go back to, all right, we are assuming that the problem is with the lungs. The lungs are not exchanging gas the way they're supposed to. And that's where you start using a ventilator. And remember, we are trained as doctors, when in doubt, intubate. Intubation is the safest thing you can do. Now you have control of the airway, you have control of the lung, you have control of the oxygen. So we have to fight against that training in this situation. And we have to be willing to put up with a patient that has lousy oxygenation. So what he was saying was, if it's not the lungs, what is it? And
in fact, and I know that we just saw, you forwarded this to us, this study out of China. Can we see this headline really quick? I believe this is still under peer review, but obviously in China now, a study come out. COVID-19 attacks the 1-beta chain of hemoglobin and captures the porphyrin to inhibit human heme metabolism. It goes on to say this, that can we bring up the next slide? Okay. At the same time, Orflab, a lot of this I'm going to have you explain. ORF10, ORF3, F3A proteins could coordinate attack the heme on the 1-beta chain of hemoglobin to disassociate the iron to form the porphyrin. The attack will cause less and less hemoglobin that can carry oxygen and carbon dioxide. The lung cells have extremely intense poisoning and inflammatory due to the inability to exchange carbon dioxide and oxygen frequently, which eventually results in ground-like lung glass in lung images. I mean, it sounds like, if it just from my perspective, and perhaps you can give me a better understanding, that this may not exactly be a respiratory issue or a respiratory disease, but something more like a blood disease. Am I getting that correct?
Right. So the whole idea behind the heart, the lungs, and the circulation is to deliver oxygen to tissue. Tissue needs oxygen to work. That's what we use for our respiration. Without oxygen, eventually the tissue is going to die. So that is the whole function of this system. Now, we're looking at the lungs because we're assuming this is a viral pneumonia. That would make a lot of sense. But what we're saying here is that that particular paper now gets a little bit complicated, but inside the blood, you have something called hemoglobin. This is inside your red blood cells. And the vast majority of all the oxygen in the blood is carried by hemoglobin. It's not just dissolved in the blood, it's carried by hemoglobin. So hemoglobin is made up of these heme particles. There's 4 of them. And what they're saying in this paper is that the viral glycoproteins actually displace the iron out of this heme protein. Iron is the critical ingredient. If you don't have iron, you cannot carry oxygen in the hemoglobin. So it displaces the iron. That creates a lot of free iron, and that can cause problems. But it also creates hemoglobin that no longer is hemoglobin. It can no longer carry oxygen. And what's interesting is you have something kind of like this that happens in malaria, and this is one of the targets of Plaquenil. You know, Plaquenil or chloroquine, hydroxychloroquine, they will actually displace the malaria drug, the malaria protozoan off of the hemoglobin so that it maintains its structure. That is one of the theories as to why the Plaquenil helps here. It keeps the heme intact in that hemoglobin so it can carry the oxygen. Because without it, your oxygen's going to plummet. So,
Now,
again,
go ahead. Go ahead.
Oh, I was going to say there are many other theories, but we do know that the ferritin, so when you release free iron, iron is a very dangerous thing to be free in the body. It creates a ton of inflammation. So when you release this free iron, the body has something called ferritin that it uses to bind up that iron so it's not dangerous. And we know one of the things that people are seeing, and I just have to say, look, I've been out of the ER for a couple of years. I'm not a frontline caretaker in the ER anymore. But we know that ferritin is a marker for that free iron. It'll bind up that iron. We know the ferritin levels are very high in these patients. So that makes sense. What they're seeing clinically on the front lines makes sense with what they're talking about with this theory, with this Chinese paper.
So now what we hear from, Dr. Cameron Kyle Seidel, he says, look, I had to leave the ICU. And by the way, when I worked on the doctor's television show, I got to spend a lot of time in ORs and scrubbing in behind the scenes. And I've seen moments where doctors have, a serious disagreement, even over a surgery table, and sometimes that can get very heated. I'm going to guess that whatever was happening in this ICU, where clearly Cameron Seidel is having an issue with how he's treating patients, and he said, I had to leave that ICU, that was probably not the softest, kindest moment that ever took place in ICU. He's now down, gone down to the ER. But he's saying now we're doing something different. We're treating patients with oxygen up front, which brings a huge question for me. If this was a respiratory issue, even if it was a respiratory issue, are you telling me patients around the world have been coming in and not receiving oxygen? If that's the case, why wouldn't they be getting oxygen? Why wouldn't that have been the first step, which he's now saying he's using in the ER?
Okay, so back to how we're trained. All right, why do you intubate somebody? Well, you intubate somebody to protect their airway, or if they've got a lot of facial trauma or something like that. But one of the biggest reasons is because they are not oxygenating their blood. So we use something called a pulse oximeter. It just measures the percentage of the blood that's saturated. And when that pulse ox drops below a certain number, whatever that number might be, then you consider intubation. So you're talking about patients where the pulse oximetry should be over 90% normally. You're going to get nervous when it drops below 90%. But some of these patients, they're talking about pulse oxes below 70%. So of course, your training is going to say, we need to intubate these people. Your protocol is going to say we need to intubate these people. So it's not a matter of oxygen, because I'm sure all of these people are on oxygen. If you have low pulse ox, the first thing you do is you throw them on oxygen. If that doesn't work, then you try other methods, and if those don't work, you intubate. That is the whole protocol. So it's really a matter of what he's talking about is using a protocol of other ways to deliver high flow oxygen and do everything you can before you intubate somebody. And then if you do intubate somebody, you don't use the ARDS protocol, which is low volume and high ventilation. You use the opposite. You use a higher volume and a lower ventilation, and you don't use these high pressures that you need in ARDS, because you just don't need it. You're just going to cause damage if you do that.
Now,
so
when
again,
you talk about other forms of delivering oxygen, I'm still curious. Before we get to this ventilator, he's doing something different. So what are the other forms of oxygen that can be delivered that he's now moving into?
Right. So none of these are optimum. So one, the simplest would simply be to have a nasal cannula and then a 100% face mask over the top of that. The second is what you're showing here, which is a high flow nasal cannula. Now you can actually deliver quite a bit of oxygen this way. The machine can deliver up to 50 to 60 liters per minute of oxygen. So that is a lot. The trouble with any of those, once you increase the flow, then you have the problem of, are you spewing virus into the air? Okay. And then a step up from that nasal cannula is to actually put on a tight-fitting mask and use some type of positive pressure. So either CPAP, which anybody who has sleep apnea is familiar with that, or BiPAP, which is kind of a modification of CPAP. But again, that keeps you off the ventilator. But those are getting into that positive pressure. You're blowing air into the lungs now, and you're also aerosolizing all this virus, and that makes it a risk for other people. So
is that perhaps why, right there, what you just said, aerosolizing the virus, do you think that's partially why we weren't moving in that direction around the world as a concern that we were going to aerosolize it all over the hospital?
I believe so. I believe that was a big concern for using CPAP and BiPAP type masks. You know, they're lifesavers in the ER. You have somebody come in an acute respiratory distress from asthma or something like that. You're ready to intubate them. You put them on a BiPAP. An hour later, they're breathing comfortably. So they are a huge, huge benefit. But again, they're a mess. They're going to be blowing everything all over the room. And if that patient has a virus, then you're going to aerosolize the virus. And even with high flow nasal cannula, that can happen. I mean, it's not as bad. So a lot of people are saying, let's put on high flow nasal cannula and then put a mask over that, because that is preferable to intubating somebody. Again, the take-home message that he was trying to deliver, and he's not alone. I mean, there are more doctors that are getting on this train because they are seeing that what they are doing is not working. A good doctor is going to look at a patient and say, we tried the protocol, it didn't work. Why? What else could be going on? Do we have all these microclots so the blood isn't flowing to the lung? Do we have a problem with the hemoglobin? Do we have some other type of respiratory problem that we're not thinking of? Why isn't this working? And then walk back from that and figure out a solution to it. So there are a lot of people out there that are a heck of a lot smarter than I am that are figuring these things out because they're on the front lines and they're seeing what does not work.
Yeah, but come on. I mean, they're seeing it, but come on, we're like months late here, Dr. New. I mean, when we think about it, what took so long? You have to imagine that in China, they were already seeing this issue. They must have had patients just like this MD in New York is describing, Cameron's describing, where they're talking to you. They're not like any other patient you've ever seen. They're doing chest x-rays. What takes so long? I mean, this is where I think we trust our doctors. We trust that they're these critical thinking people, and we got a brand new illness that is sweeping the world. Aren't they all sitting at a table together going, hey, I'm calling you, you're calling me, we're talking to CDC, there's something different here? Why are we only finding out right now because one doctor was bold enough to get on a camera, risk his career, and speak to the world? What is wrong with medicine that is taking so long?
Yeah, medicine has really become a set of protocols, and it's almost like the doctor is being taken out of the equation. You know, we really should be able to evaluate our patients and determine what's best for our patients. Now, in defense of all of that, there's something called best practices. The idea behind best practices is, hey, we went through all this research, we came up with a protocol. This is the best way to treat people that have this particular problem. And the reason why they do that is they don't want a doctor who's 30, 40 years out of medical school, like me, who hasn't necessarily read anything, not like me, but who is using the same thing they did 30 or 40 years ago. They want to have the best practices for these patients. You end up with these protocols, and the trouble is these protocols become dogma. Now, if you notice the difference between those two interviews with Dr. Kyle Seidel, the first one, he's in his scrubs. I guarantee he just got off of his shift, and he just got into a pissing match with some intensivist because they wanted to do something that he knew was going to kill the patient or was going to make the patient worse, right? And so you have all that emotion. He uses the word dogma in that video, right? He doesn't use it when he's talking to the guy from Medscape, right? He tones it way down because it is dogmatic. We are stuck with these protocols. And I'm telling you, I'm sure it's still the same way. But when I used to work, if you admitted somebody with whatever, pneumonia, you had pre-printed orders. All you had to do was sign off on them. You didn't even write the orders. They were already written by a protocol. So that's where the system has gone. So that works great if you actually have ARDS. If you have something new, it doesn't work. Everything falls apart. And we have to remember, as physicians, we have to think critically. And that's where, and again, it sounds like Dr. Kyle Seidel is an emergency room doctor. You have to think critically as an emergency room doctor, because if you don't, people die, right? If what you're doing doesn't work, you have to change directions. You have to figure out what you're doing wrong and figure out a way to fix that.
You know,
And
some sense that that's actually finally happening is, you know, I think we've all been tracking Boris Johnson, who went into an ICU recently. They were saying so that a ventilator would be available to him because he apparently is moving into that critical space. And then we saw this headline, I think it was just 2 or 3 days ago, where it is clear Boris Johnson moved to ICU and given oxygen after coronavirus symptoms get worse. So obviously they're moving away from being afraid of you know, aerosolizing the virus for arguably, I think, the most important person, the highest ranking person in the world that we've now seen get this issue. Apparently it's breaking now. I'm just being told that Boris is out of ICU. I mean, first of all, I think, you know, thank God that he is well. I think we've all been watching him. Really interesting that as we're having this discussion, they didn't put him on a ventilator, which seemed to be the protocol around the world. They went with oxygen. Clearly, I think, you know, it seems, and when you and I started discussing this just 2 days ago, it was, you know, we were thinking, is this even a story worth covering? How dangerous is it? You know, and now I think there's even statements coming from different doctors around the world. I think you shared a statement, right? Is there a new statement that there's another doctor saying he believes we may be doing more damage with, oh, here it is. Yeah. You want to read this to me? What does this say, Dr. New?
Yeah, so this is actually great for people if they want to go online and look it up. This is EVMS Medical Group. This is East Virginia Medical School, and it's Dr. Paul Merrick. So he's been putting updates online, and it's not just for doctors and nurses. There's actually preventative mechanisms in there. Things that, you know, I've been telling my patients to do, the various supplements to keep people out of hospitals, and then also just different levels. This, you know, at level 1, this is what you do. Level 2, this is what you do. But he's talking about all the things that we just mentioned here. So, and he is a director of, I think, their intensive care services. I might be misquoting, but he's involved with the East Virginia Medical School. Okay. So, you know, that's pretty mainstream. He's also talking about using vitamin C, about using vitamin D, about using other supplements, not just medications, and that seems to be making a difference for the patient. So, you know, Dr. Kyle Seidel is not on his own. There are other people out there that are seeing this, and this is what doctors do. When you see a problem, when what you're doing doesn't work, when the traditional approach doesn't work, then you need to do something else. That is the entire basis of my practice here in Ann Arbor. That's what we do, because people come here because the standard has not worked for them, and we try to figure out what's wrong with them. And that's what these doctors are doing. God bless them. That's what these doctors are doing in these ICUs and ERs, is trying to figure out better ways to do it. Sorry, but if you're waiting for the CDC to tell you what to do, I think that is the wrong approach. You got to listen to these people that are in the field, who are seeing what is working firsthand, and listen to what they're saying and start adapting that. And then maybe you can get the CDC in there to come up with some consensus for how we're going to treat this in the future.
So Dr. Merrick, even in that email or whatever was put out, he said we need to be avoiding intubation and using ventilators at all costs. Obviously, it's the last ditch. If we're losing, we go there. But he's warning, do not start here. We need to try and prolong this, use every other means necessary. So clearly, this, I think, story is one of the biggest growing stories in medicine around COVID-19. It clearly is. There's a lot of science. There's studies now coming out that we were absolutely wrong. This does not appear to be a respiratory illness. This is much more like a blood illness, and we've got to now tack and move in a different direction. In your mind, I know that, you know, as you said, in your clinic, you're looking at other things very quickly. When you look at this, when we're looking at oxygen, what are some of the things you might be thinking should be studied immediately as we move forward as possible treatments, if we know that the heme involvement, the iron, the binding of oxygen in red blood cells? What are some things that you would like to see studied immediately under these circumstances?
Well, one of the biggest things, if you're talking about the blood not being able to carry oxygen, you know, that's going to bring up a couple of things. One is like altitude sickness, where you just don't have a lot of oxygen in the air, and so you're hypoxic because of that. And the other is the bends, where you get a bunch of small air bubbles that actually block blood flow, and you become hypoxic from that. The solution to both of those things is hyperbaric oxygen therapy. Now, most hospitals have a chamber, Most hospitals have a chamber that they use to treat wounds and that sort of stuff, but you can put patients who are ill in these chambers for like an hour and a half at 100% oxygen, 2 atmospheres. The higher the pressure, the more oxygen you dissolve in the blood. You don't need hemoglobin for that. You can just have the blood carry the oxygen. And they did have a study, again, out of China. It was just a case series where they had 5 patients that they had on hyperbaric oxygen. They treated them for an hour and a half a day for 5 days. All 5 of them improved, and these were all critically ill patients. So they all improved significantly. So that seems to be one mechanism to change it. And the other thing to remember, too, is because of this, cytokine storm, I know you've spoken about this in your other show, because you have this cytokine storm, you get these tiny blood clots in the blood vessels. They're not going to carry blood the way they're supposed to. So most of these institutions are also using blood thinners, things to break up blood clots. And some people are even talking about using clot buster type drugs that we use for heart attacks. All right.
Wow.
And then the other big thing is, at the end of the day, you have to reduce the viral load. You want to keep working on what else can we use. We know that there's some evidence behind Plaquenil. Well, what about other drugs that are anti-protozoan like Plaquenil? So there's a paper out there on a drug called nitazoxanide. The brand name in the United States is Alinea. That appears to have similar benefits to the Plaquenil. So we should be looking at these things, not just saying, oh, it's dangerous. No, these are approved drugs in the United States. We're just using them off-label for things other than what they were approved for. And we do that all the time. I am tired of hearing people talk about how dangerous Plaquenil is. There are side effects to it like everything else, but it is a very safe drug. And you're talking about taking it for 5 or 6 days.
Right. Wow. Well, Dr. New, thank you for that incredible download. Thank you for your research on this. And obviously, we'll bring you back on if there's any shift in this. I think that brings a lot of clarity to what I think is perhaps one of the biggest stories in the world as we speak right now. So take care, keep up the good work, and hopefully we see more studies on things like hyperbaric and other drugs that may be able to address what now appears may not be the respiratory infection we thought it was. Thank you so much for your time.
Thank you, Dale.